Hi again, I'm Dr. Lennox Hoyte, fellowship-trained urogynecologist and pelvic reconstructive surgeon, and we're talking about mesh complications. So usually mesh can be placed one of two ways. One is the traditional gold standard route where the mesh is placed abdominally, and we're talking about mesh specifically for prolapse repair. Mesh placed abdominally is placed under what's called direct visualization, using a method where you can see exactly where the mesh is going, and you place it with sutures and so forth, such that it pulls up on the vagina to straighten it out and correct the prolapse. The other way to place mesh is through the vagina, or transvaginal mesh placement, and we're talking about mesh placed transvaginally for prolapse repair. It turns out that mesh placed transvaginally for prolapse repair can have a number of complications, including mesh erosion, pain because of the mesh, different symptoms developing as a result of the mesh placement, and sometimes the mesh not doing what it was supposed to do. And we've seen patients in our practice that have come in where they've had a transvaginal mesh placed for prolapse repair, they've had a complication, and the solution that their doctor decided to use was to place more mesh. Many patients will have that situation and not understand why it is that was done, or what their doctor was doing, or the reason behind what they did. And I'm sure that can be really frustrating and confusing for many women. So here at the Pelvic Floor Institute, when we get a patient with a mesh complication or a concern for mesh that was placed transvaginally, and they want, for one reason or another, to have that mesh explanted or removed, we really want to sit with them and first listen to what their concern is. If the concern is that the mesh is causing a complication or pain or another kind of symptoms that they don't like, then the point at that point that we would want to engage in is a thorough evaluation of that patient anatomically to try and figure out if the mesh itself is causing the complication that they face. Usually it's a transvaginal mesh if it's eroded or exposed into the vagina, or unfortunately, but rarely, into other organs like the bladder or the bowel. There's a way to evaluate and test to see if that's the case. In the case of a synthetic mesh placed transvaginally that's exposed or eroded, there's a way to remove that mesh completely. One of the advantages or one of the lack of disadvantages, for example, of transvaginally placed synthetic mesh is that it usually can be peeled out from within the tissues, usually. There is always a risk of trade-off between explantation completely, 100%, and creation of new symptoms, because sometimes the mesh can be lodged in tissues that can be very delicate and very important that could cause additional problems if you try to get it out. For example, severe bleeding that's hard to control in a mesh that's placed transvaginally that's anchored deeply. Further damage or injury to bladder or bowel, depending on the extent to which the mesh explantation wants to proceed. So it's going to be important that we have a long discussion with the patient where we review the symptoms, the trade-offs between full explantation of the mesh and onset of new symptoms, and really an evaluation of what aspect of the mesh is causing the symptoms that they're facing post-operatively. So first step will be to determine what a patient's complaint is. And many women, we understand, would want the entire mesh explanted. Those women need to understand what the trade-offs are. Certain kind of meshes that are placed just strictly in the front wall of the vagina, not anchored too deeply in the vagina, can be completely explanted if they're synthetic, fully synthetic. And that's certainly something that we would strive for. We would strive for 100% mesh explantation, understanding what the trade-offs are between 100% explantation and new onset of symptoms. If, on the other hand, the mesh is one of those what's called biologic meshes, you may have heard of the pig skin mesh that's made from animal tissue that's resynthesized and cleaned up. Those meshes tend to incorporate into a patient's own tissues, so you cannot easily separate them from the patient's tissues. So if that mesh is causing a complication, you generally don't want to try and explant or pull out all of that mesh. You basically want to de-anchor or disconnect the mesh from its anchoring point so it's not causing the pulling, pain kinds of symptoms that they otherwise could cause there. So for biologic meshes are made from animal tissue, you don't want to try to explant those because they can create new problems and actually damage tissues that they become embedded in. For synthetic meshes, there's a better chance of being able to fully explant the mesh. It's very difficult. It requires a well-trained surgeon who understands deeply mesh explantation, who understands the anatomies and the trade-off and the neighborhood in which the mesh is placed, so that they can carefully dissect out the mesh as needed to solve your specific problem. So the fact that you have a synthetic mesh in place and it's misbehaving one way or another, there's a way to explant transvaginal mesh. Many times we strive for 100% explantation. Some of us as surgeons are able to pull that off, and sometimes even the best surgeons can't completely explant 100% of the mesh without causing new onset problems, and that's an important trade-off for you as a patient to understand in order to determine how much of that mesh needs to come out. Usually, a qualified, well-trained surgeon can get enough of the mesh out to get you out of symptoms, out of significant symptoms, but the notion of complete explantation needs to be carefully thought out. That's transvaginally meshed placed for prolapse repair. If it's abdominally placed mesh for prolapse repair, then there's a way to go back in laparoscopically or robotically and identify the extent of the mesh, and usually those meshes can have a lot easier time of being explanted completely. Complication rates from abdominally placed mesh are much lower than those of transvaginally placed mesh, because it was placed under direct visualization, can often be removed under direct visualization, also by a qualified, well-trained surgeon. These procedures are not without potential risk or complications, and that's why you need a well-experienced surgeon with lots of experience in explanting meshes. So again, fellowship-trained surgeon Dr. Lennox Hoyte here. Please like and subscribe. Leave your comments in the comment section. We'll do our best to answer them as best we can. And thank you so much for watching. Well, in terms of removing mesh, there is basically a trade-off between complete explantation of 100% and the risk of creating new injuries that may be unacceptable if the full explantation is attempted. So I think in the judgment of the surgeon and within the framework of the desires of the patient, there can be an agreement made to remove enough mesh to solve the patient's presenting problem, or to go ahead and explant completely 100% of the mesh with the risk of creating new onset problems.